removing a particle of the blood. It can be white cells, red cells, or plasma, and transfusing healthy at the same time. So it's an even exchange of blood products. And we remove these products of blood because people develop antibodies, autoimmune disorders that attack their own organs and cause lots of complications. A lot of our patients are critically ill. So we roll our machine into their room, and most of our patients have a central access, which would be a catheter in their neck or in their chest that's kind of lies in the right atrium of their heart. So we run our procedure pretty quick, and it pulls out and draws out, and we have a big waste bag on the back of our machine, pulls out the particle of blood that we want. So a lot of times it's plasma, and we just throw that big waste bag away. It holds 6 liters of plasma, and we just throw that away and transfuse healthy.
A lot of people get us confused with dialysis. We do use the same type of access, but dialysis is more of a filter situation, and we are kind of like the oil change. So we're taking out the bad and then putting in the good, while dialysis is more filtering their blood.
We schedule 7 days a week.
We can have 6 patients in one day, and that takes a lot of maneuvering of the machines. It could be at 2 different hospitals, or especially if they're up in Ames, we have to make sure that that machine gets up there. Sometimes we'll get a call directly from the physician's office that's ordering it. Sometimes we'll get a call from the hospital floor that the patient's on. So once we receive that order, we get a diagnosis from the doctor, what they exactly want. We have to be sure the blood product is available. Once that order's in, we find out from the doctor how often they want it. We might have a procedure that has to be done every day for the patient, or it might be one time only. It might be every other day for 7 procedures. So it all varies according to really what's going on with the patient.
Some of our patients we treat on a regular basis, so we've become really close to these patients, seeing them, anywhere from 2 to 3 times a week to a couple times a month or once a month. So we're able to build that therapeutic, nurse-patient relationship and get to know these patients. And I know a lot of them are very thankful for the people that do donate on a regular basis, because their health depends on it.
So we get to see what's been donated out here. A lot of our patients are receiving the plasma that has been donated through a whole blood collection or the red cells.
So the blood product gets drawn here at the blood center or on a mobile. It's taken to a lab where it's processed into the different components. Then it goes to the hospital, to where we, like Debbie and I, go down to the blood bank to get the FFP, the fresh frozen plasma, or the red cells, and we have to go through each unit with the lab. We bring in a cooler up to the patient's bedside.
We're very lucky to have this service in central Iowa, because then your next place over is Iowa City or Omaha. So our patients are, very lucky to have this service close by, and we're fortunate that we're able to offer that service, because otherwise they're having to be transferred to another hospital. We do have some of our outpatients who will travel 2 hours just to get here. When the blood center says we are in critical need of this, it can have to do with us too, because we have had patients who for 2 weeks straight get those 19, 20 units of FFP a day. And
4 liters.
And 4 to 5 liters a day. And that is a large amount of blood. And at one time we had, I think, 3 patients this last winter who needed that amount of blood every day. So we know the blood center, when they say they are in a critical need, they're not just saying that.
We do all the way from pediatric. We've done month-old children to all the way, geriatric population. Yeah. So we do all areas.
In patients, we treat anywhere from myasthenia gravis. That can be basis or to maintain their a healthy level where they can function outside. We treat a lot of kidney rejection patients that can be immediate after a transplant. They might have rejection anywhere from right after or several years down the road. Those patients for us a lot of times are long term. We have a patient that for kidney rejection we've been treating now for almost 3 years. We also treat sickle cell anemia, a couple critical autoimmune diseases. We have quite a few patients we get called into that are on vents that in ICU that might be critical.
And I would say one of the most rewarding things is seeing the patient, you know, before we even start the plasma exchange, after assessing them and seeing how critically ill they are. And then after we start the plasma exchanges and they start medication, then we get to see them progressively get healthier, and it's phenomenal watching them progress so quick sometimes.